sections and then a review problem to walk through. If you haven't gotten to the opioid conversion calculation practice yet, this hopefully will answer questions for those who have, and if you haven't, it'll give you a little bit of a head start over what I'm looking for. Anyway, a couple bone mineral type stuff quickly. So here's an example of a case question you might get on an exam. This is an 82-year-old male, osteoporosis, started alendronate 6 months ago. He complains of significant reflux. He confesses he often takes some medication with food. As he forgets to do so beforehand, he also admits laying down a bit after his breakfast. Reviewing past clinic notes, he has a history of medication compliance-related issues. So out of these options, is there one that you might consider switching him to? I hear some whispers that sound correct. Do you want to shout it out? Zoledronic acid? Yeah. Why that one? It's once a year. It's IV. Yep. So would you want to use anything else in a male patient, really, other than a bisphosphonate right off the bat? Yeah. Calcitonin's a bad example as an alternate anyway. That one we really don't use at all for most maintenance type treatments. So really that one, the only role in calcitonin, just to review, is for hypercalcemia. We don't use it much to manage bone mineral related issues. So yeah, basically any patient, the moral of the story is bisphosphonates are going to be our first line to try, and if they're having some kind of a compliance issue, which is pretty much going to be the only reason why you would ever stop a bisphosphonate, most people tolerate them quite well. So you want to switch it to something that works better as far as a long-acting option. And long-acting Boniva, there is that option too, but zoledronic acid is usually the one we go to just because it's once yearly. And if you're going to give an IV, you might as well just do it once a year versus having somebody come in a few times a year to get their infusion. Okay, so this is a chronic pain case. So we've got a 54-year-old male with significant pain due to a recent tumor resection surgery, currently using 10 milligrams IV hydromorphone total per day, continuous infusion. So I've added up the continuous infusion for you. In real life, if you were converting this, you'd have to look at the MAR on a hospital chart and try and figure that out. But that's his PCA infusion, and average about 20 milligrams of oral hydromorphone throughout the day as well. So that's pretty common when you have somebody who you're trying to transition to an all-oral regimen where you've got both on board and they're trying to move the patient that way. So we want to convert to all oxycodone for an oral outpatient regimen for this patient. So first steps first is get your conversion factor. So in real life, you'd look up a conversion factor resource of some kind. I don't think I showed you the one I like to do. I can't remember if I did or not, but I don't know. I usually just Google opioid conversions. I know this sounds super scientific and nice, but there's a couple different tables you can look at that are here, like anything that's ASHP, that's American Society of Hospital Pharmacy, so that's a good resource. There's some built-in calculators, so like if you use UpToDate or if you use Hippocrates on your phone or something like that, those mostly have built-in calculators too, and those are all going to be well validated too. But the point is there's a lot of resources out there. This one I actually use quite a bit. It's like opioid calculator, practicalpainmanagement.com, which sounds made up, but it actually, I did double check some of this a long time ago, I guess I should say. But so it'll tell you if you're doing a opioid starting dose for somebody naive and like where to start with. So how much should you give somebody who doesn't take opioids? And then you have the opioid dose conversion calculation. And it says, yes, I'm not responsible if you accidentally kill your patient using my tool. And then you have these things here. So you want to convert your total daily dose, and you can select what you're going to convert to here. So in real life, again, this is what you'd have. On the test, I'll give you the exact conversion you need, so you don't really need to think about it. So anyway, you have your conversion. Your hydromorphone IV is 1.5 milligrams to 20 milligrams of oxycodone PO, and hydromorphone PO is 7.5 milligrams to 20 milligrams oxycodone PO. So we want to convert to get our total oxycodone PO equivalents here. And so to do that, you just want to cancel your units using some basic math here. So the way that we're taught as pharmacists and the way I teach people to do this is put all your units next to your total quantities. And so you want to cancel out the IV hydromorphone component. So 20 milligrams times your factor here. So you've got 10 milligrams of IV hydromorphone, 1.5 milligrams of IV hydromorphone on the bottom. And remember, 10 is your total amount that the person's using, so that's where we got that number. And that's where you get your total oxycodone. And of course, this is your conversion factor here, 20 to 1.5. And it's the same thing on the bottom to get the PO equivalent. So for this patient, since he's using IV and PO, we're looking at the total quantity. So now we have our IV hydromorphone to PO hydromorphone totals. and add that up to 186. And remember the thing called cross tolerance I mentioned very briefly in the last lecture. That's something where if you're switching from one opioid to another, you have to take into consideration they're going to get some added benefit from simply putting a different chemical substance in their system. So if you go from fentanyl to hydromorphone or vice versa, in this case hydromorphone to oxycodone, the patient will get some inherent benefit just from taking that oxycodone. So we decrease the dose by 25 to 50%. So I usually do it this way, where you take the 186 total and then you calculate it by 0.7 or multiply it by 0.75 and 0.5 to get your range. And once you have your range, you can kind of play around with how much you want to give the patient. So that's where you need to look at what's available in total, in as far as what's on the market. So let's say you wanted to give somebody, and you probably want to keep it simple. So you don't necessarily want to give somebody like 60 in the morning and 50 at night, because then you have to give them multiple prescription, multiple products. So in this case, OxyContin is the drug you're going to choose in this scenario. So what I'll give you on the test is a pretty straightforward example of converting IV to PO and looking at a straight oxycodone type regimen like this. So I'll give you a couple options, and in this case, 60 milligrams of OxyContin BID or oxycodone ER would be 120 milligrams daily. So that's the one thing where people get a little tripped up on every once in a while. Most people don't have any issues doing the math, and in fact, I think in the last couple of years, I haven't had a single person get the calculation questions wrong, so go PA students. But I would say that the BID thing does trip people up every once in a while. So just keep that in the back of your mind to make sure you've got your twice daily versus once daily, because people will forget to multiply it by 2. And that's the most common error I see people do. So now that you've got your OxyContin dose, then you want to look at your maintenance regimen. And this is where I don't really care specifically. The general rule of thumb is about 10% of your maintenance dose should be available. Most people just write as sort of a general, like a Percocet or plain oxycodone, like Oxy 5 milligrams, immediate release, 1 to 2 every 4 hours or every 6 hours as needed. And then from there, you would see how much the patient's using. So are they using a lot of that? And then you could scale it up or scale up your long-acting based on that. You don't want them to be supplementing every single hour with the breakthrough pain. That just should be a couple times a day. So that the goal is to keep them. It's okay if they use it occasionally, but you don't want them to use it around the clock. If they're using it around the clock, it probably means you need to go up a little higher on your maintenance regimen. That's basically what I said there in the first bullet point. And then, of course, side effects. So you have a ceiling effect here, so you don't want to increase it if the person's already struggling with sedation-related issues. If they're overly sedated and still in pain, that's where switching to a different opioid can help. So maybe you switch them to an oxycodone regimen, and you aren't getting the effects you want. Maybe it's time to look at something like a fentanyl patch. That's where you'd go, just to try and change it up that way. Overall, make sure you're using your adjuncts as well. So NSAIDs and acetaminophen, when appropriate, are going to hopefully help reduce the total opioid burden. Now, in chronic pain like chemotherapy-related pain, it might not do all that much, but it's still generally a good practice to keep those on board, or keep one of those on board as an option for the patient just to have available as well. Anybody done the practice questions? Anybody have any questions about the calculations? I had one question for you guys. I can't remember what the online test. We did this last year, but it worked out, so it must have worked. But do you guys have access to tab into other tabs while you're doing the exam? You don't. Okay, I'll have to talk to Lisa about it. I would just pre-plan right now on bringing a calculator with you. I think I did allow people to use their phones because most people, it's just funny how many people don't own an actual calculator. I guess I don't blame you for that. Mine's super old, personally. But we'll just say that you can use I'll allow phone use for the calculator application on there. That's okay, yes. You can? Okay, perfect. I'll just shoot Lisa an email and make sure we're all squared away, but if you guys can't, I'll allow phone use there too. So, okay, thank you. All right, so that's that. You can use scratch paper. I'll have Lisa bring like some blank paper, so if you want to write them out, you'll have that option too. All right, with that, we'll go into osteoarthritis, and talk about one of the most common conditions that you will probably encounter in your career through various steps, especially if you work primary care, but really if you work with any groups of patients, you're going to see osteoarthritis in certain degrees. So we're looking at a couple different things: joint integrity, genetics, inflammation, mechanical forces, age-related degeneration. Really, this is a disease that almost everyone will get as they age. So especially if you work with older populations, If you work with pediatrics, you might not see it all that much, but certainly for elderly populations, this is going to be something that almost everyone experiences in some joint at one time or another. Sometimes there's a key indication why they have it. They might have been, for example, I don't know, like my father-in-law was a big weightlifter for years, and he had really bad hip problems, ended up with hip replacements and things like that. So that's obviously maybe what caused that at some point, but at the same time, there might be no specific cause at all. Secondary causes are listed there, and of course, the patient's going to present complaining of pain, obviously, right? So our goal is to relieve joint pain. We want to do that in a number of different ways. We've talked about some of the drugs already, so I'm just going to sort of slot them into an algorithm for this. Improve the patient's function of daily living. And then as far as disease-modifying agents goes, and actually curing the underlying osteoarthritis, that's not something we really can do with medications. So what we're trying to do is just give the patient a little bit better of a quality of life. And then things like surgical interventions or joint replacements would be more of the ultimate intervention that would improve that person's quality of life. We can't really do that with meds. Whereas with RA, we'll talk about it as a different story, where medications are really the mainstay of improving, putting that patient into remission for their disease. You guys don't need to see my drawing to know that cartilage breaks down and bones grind against each other and it causes inflammation. So anti-inflammatory drugs are obviously going to be our key thing we're going to talk about here. But let's talk about Tylenol first. So Tylenol, I still think Tylenol is worth a shot. I think this is a bit of a controversial. I'd be curious to say, have you guys had this in other classes yet? Or is this the first you're hearing of osteoarthritis? Curious as to what professional opinions are out there. I think it's a little bit debatable whether you even use Tylenol anymore or not, just because the evidence is really scant on whether or not it actually is efficacious in patients. But Tylenol is usually the first line option. Don't forget about your topical products and your non-pharmacological things too. So exercise, weight loss, PT if they need it, meeting with a dietitian, those types of things could all be synergistic in treating OA. Topical products don't involve ingesting any substances, meaning that you don't get as much stuff in your system. Remember I showed you the diclofenac information that you just don't get as high of a level compared to oral diclofenac. So keep those topicals in the back of your head, especially if they have a small joint. I'll talk about capsaicin here in a little bit more detail in a couple of slides, but that's sort of the initial treatment that we're looking at right now. Make sure you're focusing on your non-pharmacologics, your topicals, and then for example, Up to Date would disagree with me on acetaminophen, but I still think it's probably worth a shot because what harm is it going to do for most patients? It's either going to do nothing, and then you can just say, well, okay, it's worth a shot to try it one day, or you get some relief on it and you continue it. Now, the risk, of course, is you go more than 4 grams a day, and then you possibly get hepatotoxic over time. But if you're dosing it correctly, that's really not a big deal. And remember that most pain medications should work pretty quickly. So you take a Tylenol, it should provide some sort of analgesic benefit within the time it takes to reach its Cmax, so within a couple hours of getting through your digestive system and getting absorbed. But most studies would say that Tylenol overall has a negligible effect on pain. So do you need to try it? I don't know. It's one of those things that you come into contact a lot with as far as patients who have just issues with NSAIDs for a lot of different reasons. So you kind of are left with minimal choices. You have topicals like we talked about. You have opioids, which we don't generally want to go down that road if we can avoid it. You have NSAIDs, so if that's out of the picture, if everything sort of looks bad, Tylenol is sometimes your only choice. So it's worth a shot in a lot of patients, especially if they have some of those contraindications to NSAIDs. So definitely don't kind of write it off, even though the evidence isn't great on it. It's still, again, pretty benign to give it a shot and see if it has some benefits. If the patient, that's sort of the initial treatment. So if the patient presents with more of a moderate or severe pain profile, multiple joints affected, things like that, you pretty much should go straight to an NSAID for osteoarthritis. And I'm talking about you could do a topical NSAID too, you could do topical diclofenac, but usually we're talking about systemic NSAIDs here. So we're usually giving them scheduled. So PRN at this point probably isn't going to be that beneficial to the patient. Remember, always stay on top of the pain if you can. And then requiring to suppress inflammation, time frame looking at a couple weeks probably to assess efficacy. The patient should experience analgesic benefit from the NSAID pretty quickly, but to really assess the full impact they're going to get on their disease state and quality of life, that's where you're looking at a couple of weeks for the NSAID to kick in. Again, pretty much every study out there will show you that NSAIDs across the board, doesn't matter if you're looking at ibuprofen or naproxen, whatever one you want to pick, is always going to come out ahead of Tylenol when compared directly. We talked about the risk in the last lecture. I'm not going to go through those again. We talked about some of the mechanisms too of the inflammation, but those are there for your reference. As far as choosing an NSAID, just to review, there's not really anything to say that one NSAID is better than the other. You're usually going to look at patient response, side effect profiles. Generally speaking, naproxen and ibuprofen are probably good ones to start with just because they're so commonly used, we understand them. And usually they fall on the lower end of the spectrum as far as GI bleeding risk, if you remember back to last lecture. So I like naproxen personally because it's got a longer half-life, and if patients are taking it around the clock, we want to get it scheduled. It's twice a day. Some people don't think naproxen is quite as potent as ibuprofen. So maybe with ibuprofen you get a little bit better of an effect. But if you're taking that regularly, that's 3 or 4 times a day usually. So you have a bit of a disadvantage there. Diclofenac's well studied in this area. Meloxicam, remember, is a once daily option. And then you've got your COX-2 selective Celebrex too would be probably an option to consider, especially if people have history of GI issues or GI bleeding or are on an anticoagulant. You might consider that. And then especially remember your, we'll talk about proton pump inhibitors in the next module, but your acid suppression regimen to protect the GI tract while they're on an NSAID. I won't test you on that tidbit in this lecture, or in this module, but just keep it in mind. All right, topical products. Again, you can use these. Usually, I don't know what the general consensus is on if people think diclofenac gel could be used with a systemic NSAID. I think generally speaking, people are going to use one or the other. Try the gel or try the patch and see if it works, and then maybe move to the systemic version after that. You could potentially do both, but if you're giving it systemically, it should be getting to that site you're trying to apply the topical thing to anyway, so I don't know if you're going to get a benefit from that. Capsaicin's a drug we didn't talk about last time, and it really only has an application. Well, it actually has another application that I'll talk about a lot later. But anyway, for pain management, it's kind of an interesting topical cream that actually has the component of hot chili peppers in it. So there's a bunch of different mechanisms that they think works, but there's something called substance P, which gets produced during inflammation. And by giving capsaicin, essentially you force the body to deplete all its substance P, and over time it can't make those pain signal transmissions as quickly or as effectively. Mild to moderately effective. There's no systemic absorption or side effects. However, because it's based on chili peppers, it is irritating. So usually people don't really feel it on their skin, but certainly if you touch like a mucous membrane of any kind, you would definitely feel it. So make sure you telling your patients about that to make sure they wash their hands after they use it. Lidocaine patches, again, we talked about last time, mostly for neuropathic related pain, but certainly could be tried for osteoarthritis as well. And then a new drug that we're going to talk more about during the psychiatry lectures, but duloxetine is brand name Cymbalta, which is an antidepressant that's been on the market for quite a bit. It inhibits both serotonin and norepinephrine reuptake in the central nervous system. So it basically increases the amount of serotonin and norepinephrine your body has to use. And in the brain, that helps with mood. What they found is drugs in this class have an impact in pain. And they started to get used pretty frequently in neuropathic pain syndromes. And actually, Cymbalta or duloxetine has been studied pretty extensively for not only neuropathic pain, but they're like, well, let's try this in other pain syndromes as well. And in osteoarthritis, it's actually some good evidence that it has a pretty big impact. So it's one of the first movements towards using drugs that aren't just like our typical anti-inflammatory type products, using some sort of a different mechanism of action altogether. You can combine a drug like this, SNRI, with NSAIDs, just fine. There's no side effects or interactions that increase with that. So if you have moderate to severe osteoarthritis, some people are recommending maybe starting this right away as a long-term treatment option. Multiple joints affected, also consider this. Or, of course, if the other options aren't working. So, again, those people who NSAIDs aren't effective, you don't want to do an opioid on. You tried Tylenol, it doesn't work. Topicals really maybe aren't an option. This is almost your only choice at that point. Yes? So in depression, it takes a while to work. In pain management, it's a little more tricky, and they don't know. Usually it'll be a faster onset because you don't have to. So the reason why it takes a while to work in depression, it takes your brain a while to react to having more neurotransmitter available, so usually it has to upregulate more receptors. In pain management, it's not really the case because it's working on a different mechanism, and we don't really fully understand why, but it does seem to have a much faster onset. So you're probably looking at a few days before you're going to see some effects from it. But yeah, I would still give it a couple weeks to see the full benefit before you give up on it or increase the dose or something. So for the exam, I don't want you to know at this point. We'll talk about these mechanisms in a lot more detail when we talk about psych, but I'd rather have you just know that this is an option for people. So know the name of the drug, be able to recognize it as a treatment option for osteoarthritis, but I'm not going to test you on the specific mechanism at this point. Intraarticular steroid injections. If you have moderate to severe, not relieved by oral NSAIDs, acetaminophen, your NSAIDs are contraindicated. Kind of the same thing as if, we just talked about with duloxetine. Another option for people who the other standard oral therapies aren't working. If you do give an intraarticular steroid injection, you get benefits 2 weeks after injection, and then they kind of wane after that. Most people repeat them every 3 months, but you'll see different intervals out there depending on how the person wants to practice or how they decide to give the medication. The products are essentially interchangeable. The most common one I see is triamcinolone. The brand name of that's Kenalog. I think we talked about that during the steroid lecture a little while ago, but it's an oily suspension. And methylprednisolone comes as something called Depomedrol, which is an oily suspension as well. They both do essentially the same thing. There's not a benefit of using one or the other. I think Kenalog or triamcinolone products have just been used much more commonly throughout the years, and that's one that you're going to see much more frequently. Dosing is a little bit of a art form versus the science. Usually bigger joints, bigger doses, but that's something that you'll probably see if you go and do any type of practice where they're doing those types of injections. So I'm not sure if they recommend this to be done by an orthopedic specialist in general, or if primary care gets involved in this, or how that all works. But I do know that sometimes they'll use these as sort of a bridge to a surgical intervention. So if they're going to give you a knee replacement, they might give you this in the meantime. It's not something that you can sustain for long term. Most people get diminishing effects over time with them. And so even if you're repeating it every 3 months, at the end of the day, after a couple of years, you're probably not going to get any benefit from it. So you have a narrow window of opportunity to actually get effects from this. So I don't know, you'll see professional athletes, I think about golfers and stuff who occasionally get them before a big tournament or something like that. But at the end of the day, it's not going to correct it completely, and they're going to have to do something else at some point in their life. Glucosamine and chondroitin. I pushed off the supplement lecture a couple of times, and we're going to do it this summer, but this is a really common supplement people take. It's kind of controversial in the sense that it doesn't really have good evidence with it, but that's basically the supplement industry in a nutshell. Not to rag on supplements, but just there's not a lot of money in studying supplements, so the moral of the story is that they don't have to be regulated by the FDA. They don't have to prove they're beneficial. They can't claim certain things on their label. But it is over the counter. It is marketed to people as supporting joint health. So they can say things like, they can't say, treats osteoarthritis. They can say supports joint health. So those are the weird ways they get around some of those legal restrictions. But anyway, there's not really, again, any compelling evidence. There are some studies out there that may push the needle towards mild benefit. The nice thing about this drug, if you want to call it a drug, or combination drug, is that you don't really have any side effects associated with it whatsoever. So it's pretty safe to take. They can be kind of expensive depending on the formulation people buy or what brand name. But if somebody can afford it and they want to take it, I personally don't have any issue with that. I would just say that I wouldn't expect really great results from it. However, the interesting thing is that out of all the drugs we're talking about today, this is the only option that even has a proposed mechanism that's somewhat regenerative for joint health. So glucosamine theoretically would prevent inflammation and cartilage degradation, when chondroitin can stimulate proteoglycans, which are the precursors to cartilage. Excuse me. So interestingly enough, the one with the least evidence, or we don't really know if it works or not, or the evidence is sketchy at best, has some interesting mechanisms that, if they were proven, would be pretty beneficial to patients in this situation. So again, moral of the story: if somebody wants to take it, great. If they say, I can't afford that and I don't want to mess with it, I wouldn't argue with them on that either. It's up to you personally if you think it's worth recommending or not in your practice. All right, so a little bit of a review quick on OA treatment. So you've got initial treatment, non-inflammatory, or kind of like your basic treatment. You've got acetaminophen, and again, I would still argue for keeping this in the algorithm, even though some places are saying not to even bother with it. You've got topical diclofenac or capsaicin, and then you've got your exercise, PT, weight loss arms. So those three things could all be combined as well. You could do all of them and try and give the patient benefit that way. And remember, you can combine acetaminophen with NSAIDs, whether they're topical or oral. So if you did start somebody on an acetaminophen regimen and they got some benefit, and you're like, well, they're getting something out of it, but not quite to where we want to get them, we could maybe add something on. You could keep the Tylenol on board. There's no problem with that. I think that's something that people think, like, oh, can I do those both at the same time? And you absolutely can. They're different enough. They don't stack up side effects or anything like that. You can give them at the same time. And you can even take them together in the same dose. So some people, again, people are like, oh, I think they're the same, but they aren't. And I'm not saying people like us, like people in the community more so get a little bit nervous about this. Failed acetaminophen or any of those initial options. You tried the weight loss, or maybe it's not working, or PT didn't help, or whatever. That's when you go to your NSAIDs. So naproxen or ibuprofen, again, are kind of my preferred ones. But other NSAIDs, duloxetine, something you could start at this stage as well. And steroid injections would be something maybe to consider in certain patients too, especially if you're looking at maybe getting a surgical intervention relatively soon. And then again, you fail this, you're looking at a joint replacement. Of course, we can only replace certain joints. So other ones, we might have to do other types of surgical interventions that improve the mobility of the patient, or we just can't do much about it. And then ultimately, opioids will work, right? They'll block the pain response, yes.
So where in this tree would we recommend glucosamine?
Anywhere you want. I think you could do it initially as somebody if you say, they start to see it and they're interested in trying it, or they want to try something alternative or maybe something preventative. You could say, well, this is an option. It might not work, but it's not going to cause any harm. So I'd probably try starting that earlier based on its mechanism or proposed theoretical mechanism. The earlier you start that, probably the more benefit you would see from it. And that might be the evidence-related limitations we have where we're trying it in people who have joint degeneration that's far gone, and at that point you probably can't do much about it, but maybe if you started it earlier you'd see better benefit from it. So that's where I'd probably recommend, but in at any point you could theoretically use it. And then again, opioids would work theoretically, but we don't want to use those if we can avoid them. Alright, so that's osteoarthritis, sort of your hallmark basic pain syndrome that a lot of people will report over the course of your careers. Other than that, we talked a little bit about acute pain last week, basically kind of following the WHO algorithm and talking about the different agents you could sub into those categories. So now we're going to switch gears pretty heavily and talk about rheumatoid arthritis, which has some NSAID use, but overall the management of it's quite different. It kind of falls in line nicely with this whole module we're doing as far as we talked about psoriasis, we're talking about RA. The next block we're going to talk about Crohn's disease, and those are sort of the three big autoimmune diseases that all have very similar treatment pathways. Even though they're quite different in their pathophysiology, we treat them essentially the exact same way. So again, I'm ready to start this, but I wanted to take a second for any questions about pain management or stuff we talked about during bone mineral or last week or 2 weeks ago as well. So does anybody have anything they want to discuss or bring up? Yeah.
I just have a question about this. So you really can give supplements. You can recommend supplement plus acetaminophen plus a topical all.
Yeah.
At the same time.
You could. Yep. Somebody might not want to take that much stuff at once, but certainly. Yeah.
Is Tylenol hepatotoxic if you take the right dose every day of your life?
It shouldn't be. Right, yeah. So it depends on how the person's liver function goes too. There'd be maybe caveats in there depending on their health. But yeah, a healthy person, no, it would be fine. Yep.
Then ibuprofen because you have to take the right dose every day.
Yes, exactly. There's not a lot of, there's some evidence that says if you take it with food or drink up plenty of water with it, that minimizes the GI bleed risk, but that's not conclusive either. So, but yeah, theoretically could happen to anyone at any time. Okay. All right, this is more pathophys stuff or more clin med stuff about diagnostics, but I think it's nice for me at least to review this in my head. Usually osteoarthritis is older people, not always, it can be bilateral, but it's usually more unilateral joint affected, whereas rheumatoid you kind of see the opposite side of thing. And of course the pathophys is totally different as an autoimmune disease versus kind of a wear and tear thing on the body. The big thing to think about with respect to introduction here as this bullet point here. So we use disease-modifying anti-rheumatic drugs, which is abbreviated DMARD. I'll use that term quite a bit. And that means that we have drugs that actually can like they say, modify the way that the disease works. So that's our big treatment when it comes to RA, is we want to get somebody on a DMARD regimen that is effective enough to reduce their inflammation so that they really don't have any symptoms. And that's the overall goal. We don't really, at least as far as I know, they don't really do surgical interventions on RA patients, at least. I don't know, maybe they do, but it'd be more rare. It'd be more common to use a pharmacologic-based treatment pathway. I realize that this is specialist-driven care, so with that respect, I will kind of focus you on what I want you to take away from this, but I do think it's important to talk about because it's a relatively common autoimmune disease, and you'll see it in multiple facets of medicine. So general treatment principles here. Again, I kind of hinted at this already, but any RA patient should be treated with a DMARD. It might be tempting to treat. We treat flares with ibuprofen, or we treat flares with steroids sometimes, but at the end of the day, somebody needs to be on something chronically to prevent that from happening. So that's really the push here. And then things like monitoring, seeing an expert, so a rheumatologist, having that on board is really important too. So if you're planning on going to primary care or something like that, making sure you kind of know when to refer somebody for these particular types of diseases. And if you want to go into rheumatology, well, this will be right up your alley. We've got a couple of older options that I'm going to talk about, and then I'm going to talk about some of the newer ones. So essentially, I've split the DMARDs up into two categories, non-biologic and biologic. So the non-biologic, two older ones are hydroxychloroquine, or Plaquenil is a brand name, and sulfasalazine. And then usually you give some sort of an NSAID or glucocorticoid in conjunction with this, mostly for flare purposes. Once the flare is over, so somebody presents with an initial rheumatoid arthritis pain flare, you give them NSAIDs and or glucocorticoids. You can do both if you want. And then you would wait until the drugs kind of kick in. They take a while, so 12 to 24 weeks for these oral agents to assess impact. So you might have somebody on a pretty heavy NSAID or steroid regimen in the meantime while you're waiting for these drugs to kick in, which is problematic for side effect reasons, right? Especially with the steroids. Probably more common one that's been used historically is a drug called methotrexate. Mentioned it briefly during chemotherapy. It's a folate antimetabolite, but it's kind of arguably the first-line option for oral non-biologic agents. Now, this gets a little tricky, and we'll talk about this with biologics, but there's a lot of debate over whether you use the cheaper, older drugs first, or you maybe go with a newer therapy right off the bat. And some of that might depend on how much the patient's willing to pay out of pocket if their insurance doesn't cover a more expensive biologic option. But anyway, methotrexate's cheap. It's been around for a while. It's dosed orally once weekly. You can also give it IM too, once weekly. It's got a number of different side effects associated with it. Primarily, we're looking at monitoring CBC LFTs, and patients have pretty high discontinuation rates. So 20% after 2 years and 35% of patients after 5 years. The big one that's going to cause people to discontinue it is going to be the GI issues. So people just get diarrhea, they get GI discomfort, and they aren't going to want to tolerate that for very long. It is also teratogenic. So we think about RA, younger patients, female patients, people of childbearing age. That's a big thing too we want to consider in your patients where it might just not be a smart option for them. It's also a folate antimetabolite, meaning that it has issues with the way that the body can use folic acid, and so it can deplete the body's natural stores of folic acid. So we naturally supplement, so the body has plenty of that to work with and can kind of overcome the negative effects of methotrexate in other areas of the body. Leflunomide, I don't know if you know much other than that it's just a methotrexate alternative. Most people kind of put them in the same bucket. They have very similar side effects and similar discontinuation rates. They're both teratogenic. It's not really a benefit of one over the other. The only reason why you might use one is like leflunomide is if you had somebody on methotrexate, they didn't tolerate it well, you could switch them and see if maybe they do, or if you didn't want to go the biologic route, you have another oral option here. And then I want to spend a little bit more time on TNF factor inhibitors. I kind of glossed over this during psoriasis for a reason, because we're going to spend more time talking about them here. Remember, these are our biologic agents. They're expensive. They've been around for a while. I think Humira now at this time has actually been on the market for a couple of decades now. So I think about these drugs as newer or whatever, but they actually have a fairly good track record at this point. Doesn't mean they're any less expensive. Remember back to kind of the beginning of the year, we talked about biologic products and how they're expensive because they have to be made biologically. So we can't just like make a chemical in a vat and then mass synthesize it and put it into a pill form. We have to use different bacteria that are specifically designed to produce the proteins we want to get the the specific drug. So that's where it becomes just, it's difficult to produce these. There are biosimilars that come out on the market that usually have some cost savings associated with them, but you're talking about like 80% of the original cost of the product versus an oral small drug would probably be like 10% of the original cost once you get a generic alternative on the market. So some cost savings, not a ton. But I think a lot of insurances, especially with these autoimmune diseases, are buying into these more because they keep patients out of the hospital, they improve quality of life, and over a lifetime of taking them, the compliance is quite a bit better than some of the older oral agents. So these require mostly sub-Q or IV dosing. And then again, unless the cost somehow in the future decreases substantially, which is possible with technology improvements, or maybe we just stop caring about methotrexate or just decide that these are way better. But I think they've been around enough where at this point it's sort of set in stone that methotrexate is still probably going to be what you try first unless you get these costs down. Or maybe you get lucky and your insurance pays for this right off the bat. Because I think, if it were me, I would prefer this easily over a methotrexate regimen. But again, you don't always get that decision when the drug costs a couple $1,000s a month out of pocket. And if your insurance is going to pay, then you're looking at some other options probably. So anyway, there's a lot of tumor necrosis factor alpha, TNF alpha inhibitors on the market. There's 3 major ones that have been approved and used for RA for quite a bit of time, and they're in bold there. There's some newer agents on the market too that are also TNFA inhibitors, and so those have been studied a little bit differently than the first 3. Whoops. These 3 have all been studied just by themselves as monotherapy, whereas the 2 newer agents were studied for combination use with methotrexate. So they actually combine the 2. So maybe think of it more as like a refractory thing that they would consider doing that. So Enbrel, Humira, Remicade to a lesser extent. Enbrel and Humira are probably the most common ones, and these are 2 of the highest volume selling drugs in the U.S. market. So again, if you're thinking like, oh, this is so specialized or whatever, it's actually pretty common to see patients on these. So I think it's important to spend a little bit of time talking about them, even if you might not ever end up prescribing them. They're, again, really biologics. You have a couple of things to think about in this. Some of them affect different systems more than others, but generally speaking, the ones for autoimmune diseases are quite well tolerated. They decrease the immune response without having a substantial effect on your body's ability to fight off kind of everyday diseases. So if somebody fails methotrexate, these were kind of the 2 options that are where you go from there, because you don't usually work backwards. We talked about those first 2 drugs, hydroxychloroquine and sulfasalazine. Those are really like lightweights compared to methotrexate or compared to these agents here. The drugs, etanercept and adalimumab, are essentially interchangeable. They have a little bit of cost differences, but overall you could use either one. Infliximab was, I think, the first one on the market maybe, but it's an IV only, and it's usually studied in conjunction with methotrexate. However, there is some evidence for it by itself too, but it's usually recommended as sort of an alternative with methotrexate, whereas Enbrel and Humira are more or less the first line options you would do. So you're probably going to pick one of those if you're going to go biologic on a patient. Oh my gosh, what are all these drugs? There's a lot of them, and the biologic market is growing in a pretty substantial way. So what I'd like you to be able to recognize from this is just that there's other alternatives out there. As far as a treatment algorithm goes, I just want you to focus on the basics, the oral drugs, and then the 3 drugs from this slide. I'm not going to test you specifically on these because these are, a lot of them have been approved for different indications. So you might recognize like rituximab has some chemotherapy-related uses. Anakinra is an IL-1 receptor antagonist that has some other uses as well in the autoimmune and immune suppression world. A lot of these get approved for various like lymphomas or leukemias, or they're approved for immune suppression or something like that. For solid organ transplantation, and they get moved over into other categories because they work. So again, there's a couple different options here, but just know that if the first primary choices don't work for a patient with RA, we have plenty of other choices at our disposal, but it gets really complicated as far as the mechanisms and the costs and everything like that. There's another newer medication called tofacitinib or Xeljanz that you might have seen commercials for. There's a couple other ones in the market. So I just put the one in bold because it's the one that's been out the longest. The other 2 are quite new. I've actually never seen them before, but there's this baricitinib and upadacitinib, I don't know how you say that, but anyway, there's anything that ends, so this gets a little confusing with naming, but if you're trying to remember these drugs in your head, anything that ends in MAB is a monoclonal antibody, and that's a biologic product, so think about that as like an injectable drug. Something that ends in NIB is a tyrosine kinase, or some sort of kinase inhibitor. And those are small molecule drugs, meaning they're oral tablets. They're still super, super expensive. There's a ton of chemotherapy-related applications for them, and they've been a really growing class in both chemo and in autoimmune disorders over the last couple of years. So we see a lot more of them on the market than we did in previous years. But Xeljanz or tofacitinib was one of the first ones, and it inhibits a specific kinase enzyme called Janus kinase. Anyway, it involves in stimulating hematopoiesis and immune cell function. Essentially, it's doing the same thing as the other drugs are doing, modulating the immune system, decreasing your inflammatory response by suppressing your immune system's function in certain aspects while still allowing you to have a functional immune system in other areas. At this point, these particular products haven't been studied in conjunction with other biologics, and as far as if you compare them head-to-head with our TNF alpha inhibitors, they show a slightly increased risk of general infection, so rhinoviruses, colds, and stuff like that. That's always the risk when you suppress the immune system in any capacity. Most people can take these medications without a lot of added side effects, but that is probably the biggest risk behind them. And then if you have something like a latent TB or a latent hepatitis infection, those are at risk of reactivation as well. So that's where we really watch out when we're suppressing somebody's immune system for therapeutic benefit. That's why if you've ever seen the commercial for Humira, they always say if you have Hep C or history of tuberculosis, those are the two major ones that tend to reactivate in patients who are on these particular drugs. But overall, they're pretty well tolerated, and the immune system can still function to a pretty high degree while on them. Okay, so basics, you've got active RA. So somebody comes in to the hospital or to clinic or whatever, and they have an RA flare. Let's say they're a new patient, they've never had this before, or you're suspicious of RA. They're a young patient, no history of any type of arthritic type pain. They have bilateral elbow pain for no reason. So you start them on an NSAID glucocorticoid. Sometimes people recommend starting methotrexate right away. Remember, we're talking about weeks for these oral drugs to work, whereas the compared to like a TNF inhibitor, you have a bit better of an option as far as your time frame goes. But anyway, so some people will say, well, start them on methotrexate right away. But if probably depends on the setting you're in, right? You might not feel comfortable doing that if you're in primary care, urgent care. I want to refer them to a rheumatologist clinic to make sure that they get a proper workup, and that's fine too. So I wouldn't feel like from a pressure perspective of your practice that you have to prescribe them something like that. If you were certain or wanted to try it, you certainly could talk to them about it or consider it. And depending on how long it took them to get into a rheumatologist, you might think that that's worth doing. But at the same time, that gets into the weeds a little bit on who should be prescribing what. So I won't talk more about that. But basically, in a perfect world, you would start something right away. Remember, DMARDs take a while to work. They're recommended as therapy for all patients, and methotrexate is basically the first line. So you give them something to manage the acute pain, the NSAID or the glucocorticoid, and then you add the methotrexate on board as well. And ultimately, that'll bridge them until the methotrexate starts to actually work for the inflammation. If methotrexate's an issue, you've got the other oral options. So hydroxychloroquine, sulfasalazine, and leflunomide being your alternatives there. Hydroxychloroquine and sulfasalazine are just not going to be super effective compared to these two. So really, if you had somebody who couldn't do an injectable for some reason, and they had severe GI distress on these ones, that's where you might try hydroxychloroquine or sulfasalazine, but know that you're kind of going down a step in efficacy when you do that. If the disease is resistant to methotrexate, so again, what I said was most people try methotrexate first because of its cost and because of its history, and we know it works, et cetera, et cetera. So at this point, this is somebody who's tried methotrexate on, the disease isn't responding, or you could probably put another thing in that category where and maybe a sub point here, if you wanted to kind of build on my table, you could say if they were unable to take methotrexate or another oral option wasn't effective as well, that leaves you with no oral options. So then at that point, you might just do a TNF inhibitor on its own. But usually what happens with methotrexate is if it's resistant, they'll probably add the TNF inhibitor onto it, assuming you were tolerating the methotrexate just fine. Because again, that's how some of the studies did. Of course, you can use them by themselves, and if you were having issues tolerating the oral medications, that's when you would just use the TNF inhibitor on its own. but a lot of the recommendations will say to add it onto methotrexate because you get more benefit that way by combining the two together. If you didn't want to use the TNF inhibitor, you could do methotrexate plus like hydroxychloroquine and sulfasalazine. So some people have done triple therapy studies like that and shown that that's improved over just methotrexate alone. So that's an option too if you wanted to keep it all oral or keep it all inexpensive, because all these oral drugs are, except leflunomide's kind of expensive, but all hydroxychloroquine, sulfasalazine, and methotrexate are all relatively cheap. So again, that's going to be probably the most effective regimen you could string together if you wanted to stay away from the biologic world or the expensive world. At that point, if methotrexate plus your TNF inhibitor working, or if you gave up on orals altogether and just tried a TNF and that wasn't working, that's when you want to look at maybe switching to a different TNF agent, trying one of those other biologics on the other slide, or maybe looking at a kinase inhibitor. But again, that gets kind of way into the weeds in rheumatology, and I don't want you to know that. So what I'd really focus on is just recognizing the oral agents, so the 4 major oral agents that we have, understanding how NSAIDs and steroids can play a role in flare management, and then knowing that TNF inhibitors are sort of the second step after orals either aren't effective or aren't tolerated, and knowing those 3 major TNF agents that are the common ones used. All right. I went through that really quick. Anybody want me to redo any of it or say it again or anything like that? You kind of understand. You can you can listen to me say it again, I guess, as many times as you want. Anybody have any questions about biologics or kind of what I'm trying to get at? All right. Gout. Gout's a little more straightforward, fortunately. So gout is going to be a painful inflammatory type arthritis, and it's treated a little bit differently than our standard arthritis pain, and it usually goes away and kind of comes in flares. I think of Robert Baratheon from Game of Thrones. Even though he didn't actually have gout in the book, he's like my gout poster child, right? It's kind of like drinks and eats a lot and sits around. It's the disease of kings, right? Is what they call it. So I think I think of him. So anyway, you guys are like, Game of Thrones is over. It's not relevant anymore. So let's talk about gout and just the way we can treat the flares, and then also there's some chronic management we can do. So 3 choices, basically: NSAIDs, colchicine, and steroids. So you're going to pick one of those 3 for a gout flare. And then it gets a little tricky for me to make a recommendation. So I'm going to warn you in advance that there's not a lot of good evidence for one of these 3. Essentially, you're going to kind of make a choice and see how it works. There's some things that might lead you down one path or another. And there's some biologic agents that are really expensive, but work to stop gout flares for people who are resistant to all of the above. So you might get somebody who's tried everything or has multiple gout flares, and they need to be on a biologic product. But I've never seen that. I assume that happens in some sort of an outpatient setting, not an inpatient setting, which is probably why I've never seen it. But anyway, so if somebody has a gout flare, you want to treat it as soon as they identify the attack. So a lot of times people get some sort of a prescription to take home as well, so they can take it at home if they get a flare. Usually you don't have to come into a doctor's office for this unless it's your first one. But you want to continue your treatment throughout the duration of the attack, and then stop about 2 to 3 days after complete symptom resolution. So a gout flare, usually I think of like 5 to 7 days, 2 to 3 days after. You're looking at maybe 7 to 10 days total of therapy for the average patient, which is helpful because if you remember glucocorticoids, anybody remember the cutoff point for when we want to taper somebody? 2 weeks, yeah. So you should be under that point if you're going to do a steroid burst. You shouldn't really need to taper. Again, that's up to you if you feel more comfortable tapering. I don't disagree with that, but technically you don't need to taper somebody on that. Chronic medications, there are a couple chronic medications that prevent gout flares. They aren't helpful during an attack, so it's not like you increase the doses or anything like that on them, but you don't need to hold them or anything like that. You just keep them going, and then hopefully they prevent the next attack from happening or lessen the likelihood. Okay, so we have 3 options, I said. You have NSAIDs, so we've talked tons about NSAIDs. You guys are well aware of the side effects of NSAIDs and the problems with them. So if you met a contraindication criteria to an NSAID, which I've listed down there for your reference, that would be something where you'd move on to the next category. Personally, I think NSAIDs have a good track record, and they're pretty well studied in gout, so it's a good option for the average healthy person that doesn't meet any of these criteria. Now, you're going to find a lot of people that meet some kind of a negative NSAID criteria. So glucocorticoids also have pretty good tolerability. in short terms. Of course, they have their own things with them, specifically with mood changes and hyperglycemia. So the nice thing is they don't really overlap a whole lot as far as why you wouldn't want to use this drug. So if you have a patient who has unstable mental health or is an unstable diabetic, NSAID might be the better choice. If you have a patient who has CKD, we could have that with diabetes too, but we won't get into that right now. But anyway, or GI bleed, at least they don't, it's not like the both drugs are contraindicated for the same group of people. So my point is that you can use the person's chronic history, disease history, to figure out maybe which one would be better. Or if the person has no disease history other than they just have a gout flare, or maybe they have hypertension or something, you can kind of pick whichever one you want. I find that a lot of providers might have strong opinions over which one they think works better. And again, evidence wouldn't say there's necessarily one better choice than the other, but I'll keep going here and we'll talk about that in a second. Colchicine is the new drug here. So this is a single drug in this category. It's the only drug that works like this. And so you get microtubule assembly that happens in when uric acid crystals build up in the inflamed joint. And this basically stops that from happening. So it prevents those crystals from continuing to form, and overall your body can clear that naturally. It also inhibits some other inflammatory processes. Colchicine probably has a lot of other mechanisms in how it works that we don't understand. There's actually some interesting cardiovascular applications to colchicine as an anti-inflammatory drug. Sometimes if you do like an advanced cards rotation, you might see them using it in like severe heart failure type patients. So anyway, you might see it come up there and you're like, this person doesn't have gout, but they use it for other reasons sometimes. I kind of think of this as like second or third line. The reason being is because it does cause some pretty nasty GI-related side effects. So as far as overall tolerability goes, this one is probably the bottom of the bucket, at least from incidence. Doesn't mean somebody won't tolerate it just fine. A lot of people have no issue with it. But as far as you look at incidence of overall inconvenient acute side effects, I would say this one takes the cake. So that's why I personally would recommend this as the third option. But again, people might disagree with me on that, and that's okay. There's no real right answer to this. There's also no trials comparing the efficacy of NSAIDs or colchicine. So conveniently and inconveniently, we don't have any rationale to say one are really better than the other. We have trials that say NSAIDs work for gout flares and colchicine works for gout flares separately. We don't have one that looks at the two together. Because why? They're generic, they're cheap, and no one cares. There's no money in making that study. So that's unfortunately the state of medicine sometimes we're in. Contraindicated with strong CYP3A4 inhibitors. So this is hepatically metabolized, so we want to watch out for drug interactions there. That's another reason why this drug might have some complications with it and be less desirable. It is toxic, but it's super rare to see it, so don't think like everyone's getting toxic on colchicine. So how do you treat acute gout? Basically, kind of like I said, this algorithm's a little muddy, and it's like that for a reason. You want to look at your individual factors. That's really going to break down which drug you pick. If you meet a lot of poor criteria, so like for example, they say here, no contraindications to oral glucocorticoids. Well, okay, can I use glucocorticoids? Sure, but if you have no contraindications to oral NSAIDs, you could do that as well. Or you could do colchicine. But again, I kind of like picking your glucocorticoid or your NSAID as your first choice. If that doesn't work or your contraindication, maybe try the opposite one, then pick your colchicine. But I think this lays it out pretty decently as well. Colchicine, I think, did I say the dosing of it? It's got a kind of a loading dose associated with it. It's basically double the daily dose. So you give a high dose to start with, and then it goes lower, and then you continue that same dose for the remainder of the course. You don't have to taper colchicine or anything like that. It's just a standard dose. Other than that first day, you give a higher dose. Okay, resistant therapy. Yeah.
I have a question.
Mm-hmm.
So you also like learn gout treatment. You said that we shouldn't do NSAIDs with prednisone because of the GI interactions. So you shouldn't pair those together?
Usually you don't. Yeah. So I think it's interesting because I think somebody came and who emailed me about this. Somebody, a past student, emailed me and said that somebody is recommending triple therapy, which I've never heard of in my life. I haven't really heard of any solid evidence that supports combining gout options, but besides the fact of maybe NSAID or glucocorticoid like I have there plus colchicine. So yeah, you could do maybe those two together, but I would agree that you generally don't combine the glucocorticoid and the NSAID. Is it going to cause a lot of issues? Yeah, you could potentially get a GI related issue with it or increased risk of that, but overall Yeah, that's the recommendation. Again, somebody was saying that there was a triple therapy recommendation, which I've never seen in practice. I've seen a lot of gout flares in my ER days, and I've never seen anyone use all three. So, but you might have somebody who has really resistant multiple flares or something like that, and that's been working for them with minimal side effects. So I won't knock it completely, but yeah, it's not a recommended choice. So you can combine colchicine with either one or the other. Intraarticular steroids into the joint affected by the gout flare directly is an effective option too, and you could combine that with an oral treatment as well. And then you get these interleukin inhibitors that are really expensive, which would be for somebody who's completely failing and having really bad flares that aren't going away. That would be very far down the treatment algorithm. Xanthine oxidase inhibitors are the class of drugs that are used chronically to prevent the flare-up of gout. These are allopurinol's a super common drug. A ton of people take it for this reason. It inhibits production of uric acid, so it basically prevents your body from being able to build up as much, did I say oxalic acid earlier? Sorry if I said that. As much uric acid in the affected joint, so theoretically you can't accumulate it even if you're at risk for gout, or at least you can't accumulate it as quickly. The dose ranges pretty greatly. Some people will be on lower doses, higher doses. It's renally adjusted. It's kind of all over the place where you start somebody, but that's nice because you can start them low and then work up your way to a higher dose if they aren't responding or if they keep getting flares. You have some wiggle room within the dose. Side effects, it's usually pretty well tolerated. There's some incidents of rash and some blood dyscrasia type things that are listed there. There's a newer drug called Uloric is the brand name, or febuxostat is the generic. And it's been studied against allopurinol to be not really more effective, but allopurinol is renally adjusted and is contraindicated in late-stage CKD. Febuxostat is not. So if you had a CKD patient with gout, that would be probably the one you'd end up using. Otherwise, it doesn't really have a role in therapy. Allopurinol is as effective, and it's way cheaper. One thing to think about is if you started somebody on this, they might precipitate an acute gout flare during therapy initiation, so you might consider NSAIDs or colchicine. So let's say somebody's flare resolves, they've been on something orally, like an NSAID to stop the flare from happening. It resolves, you want to start them on something, you might want to continue that NSAID while you bridge them into the therapy for a little while. Also, a lot of hydration has been shown to be really helpful during the initiation phase of these to prevent the uric acid buildup. In general, that can help with gout flares too. You can also test uric acid levels. I don't think I've ever seen this done, but it is something you could do blood tests on if you really wanted to know that specific lab value. Okay. So we take a break and let things sink, or do you want to do some review questions right now? You probably want to just get it done with. That's what I would think. Okay. Review. All right. First question. We have a 40-year-old man with metastatic bone cancer. He has been treated for chronic pain as an outpatient with long-acting high-dose oxycodone. And I say here, remember long-acting or extended release, anything like that. I give you the brand name OxyContin. That's long-acting. He has been admitted for procedure and is reporting that his pain is currently rated 10 out of 10. You want to start him on a continuous IV infusion. Which of the following medications would not be an appropriate option? So what am I asking in a nutshell? Which one of these medications is not? Yeah, I think I heard it. Oxycodone's PO only, so that's what I'm getting at here. So you could do anything to give him some sort of an IV opioid, and any of these drugs are fine. You just need to convert the dose correctly. But oxycodone would not be because you can't give that IV. All right, this is a 35-year-old man who presents to urgent care with acute pain in his left elbow during a recent fall in the ice while shoveling. The initials are a pure coincidence here. You have given him acetaminophen and IM ketorolac while he waits for your imaging. You still rate his pain as 8 out of 10. You'd like to give him a weak or partial opioid. Which medication would not be appropriate? So this is kind of that middle ladder of the WHO algorithm. You don't want to go full opioid. I'm going to go kind of opioid. So is one of these a full opioid? Hydromorphone, yeah. So Dilaudid's a full-on opioid. That's what you'd avoid. All the other ones are considered weak or partial. So remember, codeine's like 1/10 the potency of morphine. buprenorphine's a partial agonist. You'd rarely use buprenorphine, but you actually could in this situation. Tramadol or codeine would probably be the more common ones people might give somebody if they want something a little bit stronger beyond like your standard NSAID therapy, but you didn't think it was warranted to give them oxycodone. Well, would it be okay if you gave them 10 Percocet or 10 Norco? Sure. There's really nothing wrong with doing a small amount, I think, just to make sure somebody has adequate pain control. That's really common. Whether you're comfortable with that in every situation is really going to vary patient to patient. So I'm not saying you can't do that in something like this for an 8 out of 10 pain, but at the end of the day, it's your license and your decision. So if you wanted to go with something a little weaker, I think that's very appropriate in a lot of cases. So that's kind of what I'm getting at here. Okay, we have a 65-year-old female complaining of chronic joint pain in both of her hands. She's been a lifelong gardener and would like to be able to continue this hobby in her retirement. She has tried occasional Tylenol with minimal relief. She has no evidence of inflammation that you can tell. What option is the best for SR today? Okay, I heard the right answer whispered, so I'm just going to go with it. So what I would say is do C first because you want round-the-clock pain management. And even though Tylenol is a little bit controversial, she's using a PRN, she's getting minimal relief, maybe applies some relief. So make sure she's taking the correct dose and try giving it to her regularly. She doesn't have any evidence of overt inflammation, which is kind of the key mark between an initial mild case of osteoarthritis and a more moderate to severe. So you could make an argument maybe to go to an NSAID at this point, but I think the point here is that I'm trying to make is to use something scheduled and regular, and that's where I'd be going with your first choice for somebody with osteoarthritis before you'd move up and try a different medication. All right. Which of the following conditions would not be a reason to consider avoiding NSAID therapy? This is kind of a funny one. I just put this on here sort of as a trick. It's a trick. Well, it's not really a trick question. It's true, but I think people get tripped up on this. All right, I'll pose this question to you. If your kidneys are completely non-functional, can you damage them any further? Not really. So it'd be a hemodialysis patient. Actually, the NSAIDs are great in hemodialysis patients from the CKD spectrum range. Somebody with mild or moderate CKD, you would probably want to avoid them, but if their kidneys are already shot and they have no creatinine clearance to speak of, you don't really have to worry about it damaging the renal arterial blood flow like it would in a patient with functioning kidneys. NSAIDs get cleared differently from the body through different metabolic pathways, so you don't really have to worry about accumulation. You still would have to worry about GI bleeding potentially, but NSAIDs would be fine in a CKD hemodialysis patient. All right, one more. This is a 33-year-old female with a history of rheumatoid arthritis who presents to your rheumatology clinic. Been on methotrexate for 3 years with good results. She was experiencing some minor pain flares, and her dose was increased 3 weeks ago. For the past 2 weeks, she has been having significant diarrhea, nausea, and lost 10 pounds. I don't expect you guys to have absorbed all this immediately, but does anybody want to take a stab at what might sound logical? Yeah, so this falls into that kind of third tier category, but instead of adding the TNF inhibitor onto methotrexate, you just want to get rid of it altogether. She's not responding to it. The other argument, which I don't have on here, you could maybe say, like if we're talking about real life scenarios, you could say maybe, well, you go back to the original methotrexate dose because she had some effect on it, and then you add the TNF agent on top of that. But in this case, it might just be better to get rid of it altogether and start something new. Yeah.
Are you going to put the brownies and parentheses like that?
I'm not supposed to. I think I took them all off, but maybe for the biologics, I'll sneak them on there for you guys because they're complicated to remember. No one uses the biologic generic names in real life. It never happens. As you see in the names, are complicated and long and lots of vowels. Yeah. If somebody gets mad, then they can remind me nicely, or if Lisa or Wally say something, they can remind me nicely to remove that, but I don't think they will. So.